In pediatrics lower airway, we're going to talk about 4 very distinct diseases. There's just not another time that we can really talk about these diseases, and so I want to get them out there so that you at least know about them. Whereas the upper airway was sort of a differential against each other, this one, 4 discrete diseases, easy to keep them separate. Let's start off with the first one, foreign body airway obstruction. And the pathology here is that it's going to be something that shouldn't be in the child's mouth, that is, a foreign body. And the idea is that kids like to explore the world with their hands and their mouth. If they can get their hands on it, they put it in their mouth. And so the story goes the same way. You know, the caregiver only looked away for a second. So there's a kid, he's going to be young, generally less than 3 years old, who suddenly goes unattended. And as the caregiver returns, there's a sudden onset of dyspnea. At this point, the caregiver's freaking out. And you should be able to know what to do in order to evaluate and help that patient, but also you should be able to use your clinical diagnosis skills to figure out where that object is. What I mean by that is you might get a question about differentiating between extrathoracic and intrathoracic lesions. And it's actually relevant for clinical practice because it's going to help you decide who you call. If you have the object aspirated into the bronchioles, or at least into the bronchus, in the chest, when you inhale, those airways open up. Airflow is no problem. There shouldn't be any abnormal sounds. But when you exhale, you push on those airways and you close them, and so now there's more resistance. So if you have an intrathoracic foreign body, that is, it's in the chest, you're going to have an expiratory wheeze. And since it's down in the chest, you're going to need pulmonary's help. On the other hand, if it's just hanging out in the oropharynx, it's up top. When you inhale, while it does make the intrathoracic airways bigger, it makes the extrathoracic airways smaller. So if you have extrathoracic lesion, you're going to hear an inspiratory stridor. And if it's above the clavicles, that's ENT. So it helps you decide who you're going to call to help you get started. In the way of management, first, making sure the kid's not choking. If they are, give them the Heimlich, right? But what we're going to be talking about is trying to decide where did that object go. Now, chances are if they're dyspneic, it's somewhere in the pulmonary system. But to do that, you first start off with a 2-view X-ray. And what you're looking for is a coin sign. And you're looking at a coin sign in the AP view and the lateral. Work with me. The trachea itself has these fibrous rings that work around, but then are kind of floppy in back. If you had an object that was in the trachea, there'd be only one way for it to actually be displaced, and that's out the back of the floppy end where the esophagus is. So if it's in the trachea, it can only be oriented one way, that is front to back, which means that you would have a negative coin sign on the AP, because you're looking right down its axis. But if you turn perpendicular, you'd have a positive coin sign on the lateral. This means it's in the trachea. If you had a positive coin sign on the AP, it couldn't be in the trachea because the coin doesn't go that way. This helps you find out where it is, again, who you're going to call, because the treatment is to go in and get the foreign object. You are not likely to do this. Now, you might treat with antibiotics if you think there's a bacterial infection developing, but since it just happened, all you want to do is have some rigid thing go retrieve whatever that foreign body is. Well, rigid thing, what does that mean? Well, if it depends on where you're going to go. You're going to do a rigid bronchoscopy if you're pulmonary and you're in the lungs. You're going to use an endoscope if you're GI, and you're going to use a laryngoscope if you're ENT. The idea being, you're going to call someone else for help, but you're going to use the clues of the sounds the kid is making and what the x-ray shows to decide who to call. The next disease is asthma, and we have a 20-minute lecture in adult internal medicine dedicated to asthma. So this is going to be a rapid-fire drive-by, high yield only. Asthma is an obstructive lung disease that is reversible with bronchodilators and inducible in response to an antigen, that is, to a trigger. Most of the time, the patient is not in an asthma exacerbation. They're normal, but they're going to report to you the number of times that they have these asthma attacks. And so what they're going to complain of when they happen is wheezing and dyspnea. And generally, and we're talking about kids now, you're going to see the 3 A's: allergies, atopy, that's eczema, and asthma. And there's going to be this eosinophilic thing on the CBC, and they're going to have this predisposition or predilection for immune-related things. But the first time you see somebody, you don't know they have asthma. So the first time, in terms of chronic management, if you want to make the diagnosis of asthma, what you want to get are pulmonary function tests. And you want to see that the FEV1 over FVC is reduced, but that it can be reversed but to normal with bronchodilators, like beta agonists, or induced with methacholine. That is, you take somebody and they've got a bad FEV1 over FVC, give a bronchodilator, they get better. They come in, they're normal, you induce an asthma exacerbation and watch their FEV1 fall by giving them methacholine. Now, that's cruel to do, you wouldn't do it every time, but once you've established a diagnosis, they have it. And then the treatment is going to be based on 2 things. And for kids, it's really important that they avoid triggers. This means a major lifestyle adjustment for the parents, so you can coach the parents to help their kids not have asthma exacerbations. That's going to be things like getting rid of pets, getting rid of carpets, pillows and upholstery. Anything that can hang on to dust mites or cockroaches or bug feces or dander or anything that can trigger their allergies or their asthma, you want to get rid of. But most importantly, the thing that the parents can do is smoking cessation. If they want their kids to have less frequent asthma attacks, they need to stop smoking. And then you can also help the kids out by giving them medications to control their symptoms. Now, I don't want you to remember the frequency of nocturnal versus daytime versus the FEV1 to determine whether you're mild, persistent, mild, I don't want you to remember all that. What I want you to remember is that the pharmacologic therapy is done in an escalating fashion. And that as you increase in severity, you add on more medications, such that whatever you had for stage 1, or the easiest or lightest stage, you're going to retain through the others. So someone who's not that bad has a short-acting beta agonist, a rescue inhaler. Then they can add on an inhaled corticosteroid. If that doesn't work, you can increase the dose of the inhaled corticosteroid. If that doesn't work, you can add on a long-acting beta agonist. And here's the thing about asthma. You cannot use a long-acting beta agonist without an inhaled corticosteroid. It worsens asthma outcomes. It increases asthma-related deaths. If you're on all this medication and you still don't have good control of your asthma, well, the last option is oral steroids. Now, your goal will be to get people off steroids because their side effects are terrible. Good news, there's another option. It's called leukotriene antagonists. It's an oral supplement, and generally you start it right around here. As you improve the inhaled corticosteroid, you're going to add on that leukotriene antagonist, again, to try to increase symptom control. But the most important thing you can do rather than adding on more medications because the asthma is not controlled, is make sure they're doing it right, right? It's actually kind of hard to use inhalers, and some people do some pretty crazy things. So anytime you see someone whose asthma is not controlled, the answer is going to be, watch them use their inhaler. Give them a spacer. Make sure they're doing it right. And then if they are, and they really lay on that they're doing it right, you do need to add on more medications. Bronchiolitis is the third disease. This gets a lot of attention, a lot of talk, but as you'll see, not a whole lot we can do about it. Bronchiolitis is caused by a virus, most often RSV. The patient is going to be very young, less than 2 years old, present with wheezing and dyspnea. Sounds like asthma, only it's going to be in the winter months. And the kid will not have asthma, allergy, and atopy. When it comes down to this, if you diagnose RSV bronchiolitis, you don't do anything. But if someone comes into the ER and they're hypoxemic and they're looking like they're sick, you might do a few things. You might say, well, I want to rule out pneumonia with a chest x-ray. Okay. You might say, I want to rule out asthma by giving a beta agonist. Well, we know that beta agonists in the setting of bronchiolitis don't do anything, so you shouldn't. But if you give somebody a beta agonist and they do okay, you keep it going. You might say, I want to get a CBC to make sure they're not septic. The thing is, you don't have to do any of this stuff. If you have the right clinical scenario, hypoxemia, very young age, wheezing, winter months, you don't have to do anything at all. In fact, if you do anything, it's probably going to be worse. That is to say, the way you treat bronchiolitis, we thought maybe you can give some beta agonists, and that way, since they're wheezing, they'll improve oxygenation. No, turns out they're wheezing because they're sloughing off and reducing the cross-sectional surface area of the bronchioles, not because of bronchoconstriction. That didn't work. Well, okay, they're infected with a virus. Maybe we can try some steroids, right? Get that inflammation down. Nope, that didn't work either. And then, well, I said, well, okay, hang on. Maybe it's worth it just to give antibiotics. Let's see what happens. Nope, antibiotics didn't do a thing. And then we said, well, it's good to know if we're treating the virus bronchiolitis that we don't have to look for anything else. So maybe we could get, RSV antigen or antibody or PCR. And no, that just costs more money and doesn't change anything we do. So you can see a lot of crossed out lines there. So what do we do for bronchiolitis? Well, we admit them and we give them oxygen and fluids. We literally can do nothing to change the course of bronchiolitis, and the symptoms generally peak right around day 3 or 4. Basically what we're doing is the kids are so young. And if they're breathing 60, 80 times a minute and they're hypoxemic, they may not be able to feed. Right? They may not be able to grow, and failure to thrive is the thing we're keeping them in the hospital for. We don't say that. We say it's hypoxemia. But really, it's to make sure that they're able to get the nutrition that they need and the oxygen supplementation. And also to make the parents feel better, because that blue baby is kind of scary. But we know that we really can't do anything. But it can progress to full-on hypoxemic respiratory failure and ARDS. So it's not a nonsense disease. It's just that we can't do anything about it except give supportive care. We're going to close with cystic fibrosis. This is the only time we'll actually talk about cystic fibrosis in any meaningful detail in this course. It is an autosomal recessive disorder of the CFTR gene. And the patient is going to come to you almost always diagnosed. Right? It's not going to be a question of what's the diagnosis. It's going to be, what do you really care about after they've been diagnosed? But the way you diagnose cystic fibrosis in this country is with prenatal screens. It's part of a genetic panel that everybody gets who goes to see an obstetrician. Now, the test can throw wild cards at you by saying that they're an immigrant or that they did home care, that they don't believe in the healthcare system, what have you. Some excuse as to why they didn't get the normal prenatal screening. In that case, you need to be on the lookout for, does this person have cystic fibrosis, or have they got a mild version where they've been able to skate under the radar when really they do have the disease? So there's a couple of ways the test can bring up cystic fibrosis. It's going to be the meconium ileus. On the day of birth, you got to use that water enema to break it up. That's a presumptive diagnosis, and you actually do the testing. If the kid lives to be a little bit older, you'll see recurrent pulmonary infections. The reason for that is that cystic fibrosis doesn't have really good cilia, so the whole ciliary elevator doesn't work. You can't clear secretions very well. But most of the time, there's going to be a failure to thrive. And that is because the pancreas is the other organ affected by cystic fibrosis other than the lung, and the exocrine function is lost. So even if the kid is hungrily eating, they can't digest anything, can't break down the proteins, and can't absorb fat-soluble vitamins, and so there's a failure to thrive, so very rarely do they even make it to recurrent pulmonary infections. And the last one, the wild card being thrown out there, is going to be mom might say, hey, my baby tastes salty. If you have any of these, you're going to screen them. And then do the confirmatory sweat chloride test. What you're going for is greater than 40 in an infant, greater than 60 in anyone older. And once you have the diagnosis of cystic fibrosis, kind of sucks because we can't really do anything about it. There's two organs we really care about, and we've alluded to them already. That's the lung and the pancreas. The exocrine function of the pancreas is lost, and so if you want to be able to grow and thrive, you'll need to replace those pancreatic enzymes. And that's no big deal. And you supplement the fat-soluble vitamins A, D, E, and K. So nutritionally, that's not a big deal. The lung thing, though, is where you get into trouble. And so what you want to do is aggressive pulmonary toilet. Try to move those secretions and fight against Pseudomonas. Whenever a cystic fibrosis patient gets infected with pneumonia, it's Pseudomonas. Big asterisk there. The incidence of Staph aureus is increasing. Still want you to learn Pseudomonas. The problem is, even if you do all this stuff, their life expectancy is to be about 45 years old when you die. They're going to be malnourished and generally short stature just because of that failure to thrive, and they need to be counseled on their genetics. One, because likely they are to be infertile. Most men have immotile sperm, but you also need genetic counseling to make sure that you don't procreate and pass this disease on to somebody else. So these are 4 diseases: cystic fibrosis, recognize the different ways it can present and then know how to manage the lung and the pancreas. Bronchiolitis, it's RSV, young kids, supportive care. Don't do anything if you know it's bronchiolitis. Asthma is going to be the reversible obstructive lung disease. Really go for the smoking cessation and then the inhaler use. Those are the 2 things you can do in primary care for pediatrics to make sure that the kids get the best thing for them, make sure they're using their inhalers and that parents aren't smoking around them. And then foreign body airway, basically you want to get to the point of, I know where it is, so I know who to call. And generally, if they're dyspneic, it's probably going to be pulmonary to do the rigid bronch. That is pediatrics lower airway.